Hey, good evening, everyone. Welcome to our bariatric surgery webinar. My name's Angie Bunkley. I'm our bariatric surgery program coordinator here at Tallahassee Memorial. We've got lots of good information for you tonight. We will have plenty of time at the end set aside for questions and answers. So if you will, just jot down your questions. Feel free to enter them, and we will talk about those at the end. We've got two speakers tonight. I have Mr. Greg Laffitte, who is sitting here with me. He is a bariatric PA with our program. We also have Dr. Joey Jarrard. He is the medical director for the bariatric surgery program. Also, we will be doing a drawing for a Publix gift card winner. So we will do a drawing at random, and we will notify the winner tomorrow via email. I'm going to go ahead and hand it over to Greg. Thank you for joining us tonight.
Okay, good evening, everybody. I looked at my phone here a moment ago, and the temperature outside is 43 degrees, so I can think of no better place than to be in front of a monitor or your phone or whatever device you have to be able to get some good information tonight. Some ground rules up front. There is no such thing as a stupid question. So at the end of this, if you've got a need for clarification, want further information, please make sure you ask us about that. The other ground rule is now's a good time if you want to go get a cup of coffee, some tea, something hot, maybe something to write with, a pencil or otherwise. Let's get prepared to give you information that I think it's not stretching to say that this could be life-changing for you. In your homes there, if there are people that are with you, I would encourage them also to come sit down and pay attention to what you're about to hear, because the business of bariatric surgery can change your life. And what we're going to go over, every bit of this is important, so let's just get into it. A lot of information, we've tried to boil it down to things that make a difference. Starting off with, there's a team that we have. I'll make sure we discuss that. I'm going to go into the details of the disease, obesity, and make no mistake about it, this is a disease. The challenges that people face with this. It's important to understand what it's costing you, not in terms of dollars, but what's it costing you in terms of your happiness, how you can get out and enjoy life. Options. The surgeon is going to go into those details for you, the benefits, of course, and then we're going to go into the salient details of what do we do next. So a lot to learn. I ask you to get comfortable. Let's take some moments and understand that what you're about to hear over the next hour could certainly change your life. It's extremely important, and I get a lot of fun out of doing this and helping folks realize what their potential is. So here we go. All right, you have a team. This is going to be somewhat different possibly than any other medical experience that you've gone through in the past, because there is a big team that's going to help you to reach your success. Now, you're going to have friends, you may have some family members, you may have social media that's going to bring opinions to you and try to make you have ideas that may be counter to what we're going to present today. So right off the bat, I'd like for you to appreciate the fact that the team that we have is comprised of professionals. It starts off with the bariatrician, that's me, registered dietitians that are absolutely fantastic. Got some nurses. I've got a fantastic behavioral therapist. We have a young lady over at Premier that's an exercise physiologist that's fantastic. And then, of course, I can't give any greater homage to the surgeons that we have. So there's a great big team here that helps you to realize your success and to help you maintain that. And that helps not only you, but that certainly helps your family. So a great big multidisciplinary team. All right. Bariatrician. You may not have even heard of this word in the past, but that's a description for people that specialize in treating obesity and obesity-related diseases and the conditions that you face. Okay, I can help you with something that would be non-surgical, medical, if you will. But the idea is that we focus on the health needs of those individuals, and I practice obesity medicine. We call it bariatric physician. I happen to be a physician assistant. You could use those terms back and forth how you like. Dr. Angie Kane is our medical director, and I'm the in-resident bariatric physician assistant. Been doing this in May, will be 9 years coming up on 10. And I think my numbers of experience with patients in and out and rotations and follow-ups is over 9,000. So I feel pretty comfortable in being able to help you. The additional parts of the team, up in the top left-hand corner, that's Christine. This is a young lady with a master's degree in exercise physiology. We're interested in people getting moving. Lifespan is important. Health span is probably more important. And nowhere is there a greater need than someone that can teach you a way to work out smarter and not necessarily harder. We don't need you to be able to go to Kilimanjaro tomorrow evening or run the Boston Marathon. Top left-hand or right-hand corner for you, that's Catherine. That's our clinical therapist, if you will. Right beneath her is Katie. Katie is absolutely phenomenal. So is Nancy, and so is Ann. So there's a very powerful team that gets extremely passionate about helping people. And I don't think you'll find anybody else any better at all in the team that can help you out. Top left, Dr. Joey Jarrard. Got top right over here, that's Dr. Parker. Bottom left, Megan Bell, PAC, if you will. And then there's Courtney. So if you look at this and try to gain some understanding of who's going to help you out, you will not fall short in terms of having people that A, care about you, B, are compassionate about you, and C, want to help you realize your potential. Now, program coordinator, it starts with Angie. And Angie's the one that brings all of this business together to be able to have the raging success that we've been able to achieve. Highly, highly credentialed individual. And this is somebody that if you have a question, she has the answer. And if she doesn't get it, or doesn't have it, she certainly knows where to get it. I'll pause here just for a moment because I think it's extremely important before we take a step further to have the appreciation for this is a program, and there are a number of people that are dedicated to helping you realize your full potential. So what does full potential mean? Whether you're 18 years old or whether you're 68, you might even be in the 70s. Our job is to help take a disease state that you have and help you overcome what it has done to you. It makes no difference how you got there. What's important is how do we coordinate this care moving forward so that you'll be able to realize happiness, I want to say the word harmony, but to be able to get out and to enjoy your life for the years that you have here remaining. And the people that we have on our team are coordinated to achieve that end. All right. Might want to write down some things here because this is where it gets important. This is where it separates the professionals from the wannabes. Before surgery, you're going to have an encounter to be able to discuss metabolic or medical causes of obesity. You will be, I'm sure, reminded that you may have come across people that have been judgmental. They might have even made you feel bad. There may be any number of adjectives that make you think that something that's going on today is your fault. And I don't have any time for that type of attitude. We want to look at this as it is a disease. And make no mistake about it, it is a disease, and it's characterized by, gosh, it's chronic, it's years, it relapses, you lose some, it comes back. You know, raise your hand. Of course I can't see you, but raise your hand if you've ever had a diet only to have all that weight come back again. Yeah, so it can be very challenging. It's just, there's a couple, 4 that raise their hand. Good. The idea here is to have the appreciation that we're about to change your world because we understand that it is a disease and it's chronic and it relapses, and it doesn't just show up with what you see in the mirror. It brings what I call multifactorial components. What do I mean by that? High blood pressure, diabetes, cholesterol concerns, obstructive sleep apnea. And I know there are plenty of people that say, well, my knee hurts or my hip hurts, and the orthopedic specialist that I've gone to has required that I lose a certain amount of weight to be able to undergo having a hip or knee replacement. We take these things into consideration and go into the depth to determine such as whether you have an eating disorder. I've got a therapist that's phenomenal. Catherine Madsen is second to none. I'm going to open your chart and I'm going to look at your medications. The nursing staff we have is fantastic. They're going to reconcile your chart. Now, why is that important? You're going to fill out some paperwork when you come see us. You have to do that. I get it. But I need to know, are you taking a medication that for many, many years has contributed to weight gain, or it might even prevent your weight loss? I'm going to order blood work. I want you to go over and have some fasting labs done so that I can then assess to understand what is your hemoglobin A1C status? Where are you with regard to liver function? What about thyroid? Just to mention a few. We really stress changing behavior. That's not to suggest you don't know what to do, but this team and this program that I mentioned earlier, we're going to come together and coalesce into a force to be reckoned with, and that is to help you make the changes in order to have long-term success. When this weight comes off, we want to help you maintain that so that in the years to come, it doesn't return. So that's improving nutritional, some intake, and some habits. And no, we're not going to have you live on lentils and water and protein shakes. That's not what we do. And the dietitians are just phenomenal at being able to educate you into the science of this. When you meet with a live person sitting across, chances are they're going to give you some details of some things very specific to help you understand that it's for you and not necessarily in a group. So it's going to be very individually tailored, if you will. And our idea, last sentence on this page, we want you to get in the most healthy physical state possible in order to have a long-term surgery. So that's what we can do before the surgery. And I have to suggest and remind everybody out there that I'm coming from an angle where you probably have had experiences where you've done everything you can. You're frustrated. You hear a friend that says, well, I'm on Ozempic, or I'm on Mounjaro, or I've got Wegovy, or I've got whatever, and I'm tempted to go down the street to this doctor's medical weight loss place that's in between a massage parlor and a pizza joint and start getting phentermine. Or maybe I'm going to get a compounded drug and I don't know where it came from. That's not what you get here. This is a professional setup, and we're quite competent at what we can do. And I'm extremely confident that we can help you achieve your goals. It's a big deal. I think it's important that we say accountability, responsibility. Are you ready to do this? Are you ready? Here we go. Are you ready to give it your maximum effort? Because that's what we want to do to help you appreciate what needs to be done and continue that after that surgery. I'd like for us to position you such that the 3 months that it generally takes to have you ready for a gastric surgery, so that you go to surgery that day and then you wake up in recovery, you go to the floor, and as a rule, your surgeon will keep you at least one night. But we want you to be in that position such that when you wake up and it's time for a family member to help you get home, that when we go into the post-op recovery period, that this is not foreign. You've been there, you knew to expect what was going to happen and how the structure was going to change your life as you move forward. And so you say, well, what changed? How about the loss of 100 pounds over the next year? What about the loss of 150 pounds? What about seeing your diabetes go into remission? What about, hey, my knees don't hurt like they used to? So this changes. Dietitians are fantastic at helping you understand what nutrition means. And I don't mean, okay, well, we're going to have more fruits and vegetables. It's far more important than that. They're going to go into the details to tell you the quantity. They're going to explain to you a complex carbohydrate, why the complex carbohydrate with high fiber makes such a big difference. And of course, we're going to have lab work. We're going to follow it because we want to make sure that you're staying in the nutritional columns that lend itself and yield the results that you want. Now, furthermore, and it's not on the slide, but we do a body composition analysis, and it's a fantastic tool. It's not the best that's out there, but it's the best that we have. You have to imagine that when I suggest I want you to lose weight, or you've come to me to help you lose weight, I want you to lose the correct weight. And that means we're going to take and get rid of adipose tissue. We want to hang on the muscle. So it's a collaborative effort by a very professional team that's coordinated before, during that surgical workup, and then we follow you afterwards. So there's a lot to look forward to. This is, as far as I'm concerned, this is an exciting opportunity for people to be able to make the changes where in the past it simply hasn't worked. You've done what you could. All you're asking is for someone to be understanding and to give you some assistance. It starts by having the appreciation that it's a disease. It is make no mistake about this. This is a disease. And generally speaking, and I do see exceptions to this, generally speaking, when you see the increase in body fat, it's going to stimulate the production of other problems. Now, that big picture there in front of you, it may be a little bit busy, but it's extremely important for you to understand in terms of what the physiology of the body does when we begin to carry a lot of extra unhealthy weight, the number of negative consequences. So how do we define it? I'm not sure who asked that, but I'm going to answer that question. In the office, when you come in and you see us, I'm going to take a little device out. I'll hold it out. This is one of the ways that we have as far as measuring you. Now, this is not designed to make you feel bad. I'm not interested at all in hurting your feelings. I'm interested in helping your feelings and help you become successful. Excuse me. Help you become successful. All right. A BMI greater than or equal to 30 is going to be considered to be obesity. And you go through class 1, class 2, class 3. Now, why is this important? Because those numbers right there are going to dictate, in a few more slides, I'll go into greater detail. But the preface behind this is that you're a candidate for surgery should you have a BMI 35 or greater. And we'll get into the business of how many comorbidities you must have in order for your insurance company to cover this for you. Big important slide. Brace yourself. Here we go. Perception. I can't tell you over the number of years how many times I've had conversations with people and they reveal it's a very personal thing to begin with. It's extremely personal to come in and talk to someone about your health, especially when we get involved with about weight. You might have seen and experienced this, thank you, in your own walk, in your own experience as receiving medical care, is that somebody might have made you feel, either they said it directly or they might have inferred it. Here we go. This is the way it used to be, that obesity was your weakness and that it was your fault. And that the only way you could get around this was diet and exercise. And that weight loss surgery, listen to this, oh, it was dangerous and that it was extreme. No, that's the way things perhaps used to be. And in some circles, some people may still see it that way. But if you come over here and you get involved with us, this is the way it is. Obesity is a disease, make no mistake about it, and it's the cause of a lot of problems. It causes a lot of problems. It's not just stepping on the scales. It's not just putting your bathing suit on and looking in the mirror. It's not just, oh, I'm short of breath when I go up the stairs, on and on and on. It's a disease and it causes a lot of serious health conditions, and surgery is an effective way. I have seen over the years 100 pounds gone, 150 pounds gone, 200 pounds gone. I've seen people in their 70s that would come to me and say, Greg, I can't get this off. And a very dear patient of mine, she's in her 70s. She enjoyed going touring on cruise ships with her friends, but before the weight would come off, she couldn't do it. I think she's on a cruise somewhere right now. I've had a number of men that I can't get out and play like I used to. I know a guy that now rides his bicycle 50 miles every other day. So surgery helps people to realize those goals. So changing perceptions are incredibly important. There was the past, there's the present. Now, if you examine your own health experience, this is almost an incredible concept if you've never really had that conversation. But pay very close attention to this and make no mistake about it. The fat in your body is a gland. It's an actual endocrinological organ. And many people will say it's the largest gland in your body. Now, that's important because it secretes hormones. Hormones and inflammatory factors that can cause the following. And I don't, of course, ask you to raise your hand. If we were in a classroom somewhere, we could have some interactive stuff with this. But the family members that might be sitting there with you, I want you to look at each other and go, yep, that heart attack thing, been there, done that. Stroke, oh yeah, don't want that. Diabetes, oh yeah, everybody got their hand. Not everybody, many will do that. Joint pain, how about that? Inflammation, to name just some of these problems. These are the things that are going on that you may not have had. 8 years old, I was fine. 18 years old, I was great. Get married, go to college, have some kids, maybe go through divorce, have a bunch of stressful things that occur. COVID comes along. golly, next thing you know, we're fighting this BMI that might be where you're 100 pounds, 150, 200, whatever number of pounds overweight. And these are the things that show up with it. How's that kind of a relationship to you and your family? Well, think about this. Call your mom and dad up. Say, hey, look what you gave me. Thank you very much. I remember seeing a child that was being baptized at church one time. And an older lady came up at the end of the service and looked at that child and said, that's the ugliest baby I've ever seen. Bless his heart. You can get away with that a little bit. We can't pick our parents, of course. So there is that good chance that you're going to inherit, if you will, some of the genetic predispositions for them. Now, let's preface something before I go further. You do have a degree of personal responsibility because genetics can be equivalent, if you will, of putting a bullet in a gun, but it's your personal behavior when you pull the trigger. When you pull the trigger. Ethnicity, yeah. Medical causes and diseases. Oh, yeah, if you become sedentary because your knee hurts, well, then I understand. There's going to be some changes. What about hormonal influences? Young lady came and saw me today because of significant endometriosis. She had to have a total hysterectomy in her 30s. What change did that have? What about having had children? What about the stress of having to care for an aging parent? You can take whatever example that you can create with this and say, yes, hormonal influence play a huge role. Perimenopausal, postmenopausal, stress, lack of physical activity. Mindful that the vast majority of people in the year 2025 probably do more work at a keyboard sitting in a chair than they do loading a railroad car or working in a logging camp running a chainsaw or physical hard labor. Yeah, these are factors. It's real. The environment that we live in. I live 3.2 miles from where I sit right now, and on the way to my house at lunch or on the way home for dinner, there are 23 places that I do not have to get out of my car to go in and get something to eat. When I go to Home Depot to buy lumber or tools, there's always a Twix bar or M&M staring at me. And if I'm lucky, I can buy them, throw away the wrapper before my wife catches me. Food's there. It's everywhere. And by the way, there are some medications associated with obesity. Some of the psychiatric medications that we have seen. So there are a number of factors. You take this list and you can see, you can plug you into where this list lays out on the screen and say, yeah, look at all that. And does that explain it all where I've done everything I can and I can't get ahead? And then my next door neighbor, they don't have to do anything, but look at that. Well, there are causes that are out there. And you're here tonight to go, how can this TMH organization help me? You're in the right place. Let's keep going. This is my scary list. This is the one that I look at that and I go, oh, cardiovascular disease. Yep, check, got that one. PCOS, no. Vitamin deficiencies, get up every morning and take vitamin D. No diabetes, sleep apnea. I know a lot of people that do. Eating disorders, I don't see them so much. But when we do, when we suspect them, then you get to see Catherine Madsen, who is phenomenal. Fatty liver, see that routinely. Depression. Young gal that came in depressed today. She lost a child. High cholesterol, very common in the world we live in. Respiratory disease, oh yeah. You see what's on there. These are the kinds of things that we think, okay, associated with obesity, and it's out there. And it's something that has become so commonplace. You're not in this by yourself. Now, does that make you feel better? You know, it's designed to say, yeah, it affects a lot of people. Affects a lot of people. 42.4% of US adults obesity. That means if you're sitting in a car, look to your left, look to your right, chances are somebody in that car is overweight. Now the 9.2%, that's those that have severe obesity. And that's a serious thing. If you take this a little bit further, the number's getting worse, larger. And when you put this in context, you must consider where do we go? What do we do? You're sitting there tonight, you're here at this seminar, and you're going, all right, what am I going to do about this? All right, you're in the correct place. Why? Because our management goals, I want to improve your patient health, improve your quality of life. Now, I say these to people multiple times a day. And let's talk about improving patient health. Who here wants to go to dialysis? I don't see any hands going up. Who here wants to go around with an oxygen tank? Now, here's a serious question that makes everybody stop and you kind of go, yeah. Have you ever been to a nursing home? Have you ever had to care for a patient in hospice, a family member? Have you ever had to take care of someone who can no longer fend for themselves? So we don't want you to be that person. We want your health to get better. I want you to be able to say, I'm going to retire here in a couple of years. I want to be able to get out and go see the world. My favorite movie is It's a Wonderful Life with Jimmy Stewart. And he, in that movie, in the very beginning of it, is quoted as, I'm going to see the world. Well, you can't do that if we have obesity knocking at your door, degrading all of these metabolic disorders. I want your body weight to get better. I want the composition to get better. Why? Because that's why we're out here. We want to be living and be happy. So, think about this. How much can it help? Now, you take a piece of paper and you write down what your weight is. And when you come in and you see me, it's not going to be much I can do about it right this point. But I want you to understand that if you're 100 pounds overweight, 100 pounds overweight, if that's considered as your excess weight, we can probably get about 70% of that gone. Now, picture that. Today is the 9th of January, 2025. What if I could have you in the operating room in 4 months? And then what if we say, okay, so that's going to be February, March, April. How would you like April, or Christmas rather, even that? How would you like at the end of Christmas season next year to have changed your life by losing 100 pounds? Particularly when you appreciate that you've done everything you can and you can't get there. That's where surgery comes in, and surgery can help. Let's take this a little further. BMI, I mentioned this earlier. I'll sort this stuff out when you come see me. Are you a candidate? BMI of 35, greater than 35, with at least one comorbidity, or a BMI of 40. Without. Healthy enough to undergo a major operation. Now, we're going to do the clearances that are required to help to determine that. We're going to look and say, yep, they've been trying since 2015 and nothing works. They lose some, comes back. Lose some, comes back again. I'd like to make sure that we don't have, excuse me, one second. Drug and alcohol problems. Now, if it's there, we've got a therapist. We can get you through that. The business about uncontrolled psychological conditions, not being treated, we need to treat you. Let's work through that. Then we have a multidisciplinary team. Angie's part of that. The surgeon's part of that. They look at all of the factors that are associated with your healthcare in your health record and make a valid understanding and decision about that. And then, of course, we want you to understand what the surgery of risk, what the risks are associated with it. But the big picture about this, you have to be ready to make these changes. In my office, I've got a board I put up last year around that. We got back from Christmas vacation. It says on there, are you ready? Well, you're ready if you go, all right, I've done everything I can. I've tried. I've been sincere about this. My body does not cooperate with me. How do I find my health that's been so elusive? The next slide says this. What are your surgical options? Now, it's been my pleasure to have had the opportunity to direct and talk about this subject, because I could go on this for several hours and tell you all the fantastic success stories that we have had. But now's the point I'm going to hand this over to the Luke Skywalker surgeon that I know is Dr. Jarrard. So it's been fun talking with you all. I hope that you hang around if you have some questions. don't hesitate. So here goes Dr. Jarrard.
Thank you, Greg. Okay. Well, thanks again, Greg. Thank you guys for joining us this evening. I'll be quick going through some of this stuff and allow plenty of time for questions at the end. I just kind of want to give you guys an overview of the surgeries that we offer here at TMH and convince you that they're safe and that they're effective. So just to jump right in, overall, we divide bariatric procedures into restrictive and malabsorptive operations. Restrictive operations are just that. They restrict how much you take in at one time. A gastric band or the lap band was a very common example of this in the early 2000s, and that's kind of gone away over the past 10 years or so. The sleeve is the newer version of our most common restrictive procedure. It killed the lap band just because it works better and it's a little safer. But that just makes the stomach smaller. You take in fewer calories, you lose weight. It's very effective, very safe. Malabsorptive procedures are just that. They influence how you absorb food so that you don't. This is the most common example of this. And biliopancreatic diversion or duodenal switch is another example of this. The duodenal on malabsorption, and I'll talk a little bit more about all of these. So the gastric bypass, as you can see here, we divide the stomach into this small little pouch, separate it away from the rest of the stomach, and then we divide the intestine. The bottom part of this intestine, the jejunum, gets connected to that stomach. So when you eat, the food goes through the stomach directly into the intestine. Now, the duodenum here, or the other portion of the intestine, just gets plugged in further down. So everything remains in continuity. All of your digestive enzymes from the stomach, gallbladder, pancreas, liver, all still flow through the intestine and help you digest the food that you eat. You just bypass the first small part of the intestine. The sleeve is a little bit more straightforward. We literally take a stapler and divide along the side of the stomach. So your stomach looks more like a narrow tube rather than a large pouch. So it significantly reduces how much food you can take in at one time. That portion of the stomach is removed. That is permanent. You just take in fewer. So there's no rerouting of anything, no malabsorptive component to this. The duodenal switch is a little bit more involved and is honestly kind of a combination between the two. The first step of the switch is actually to perform a sleeve. So you get a sleeve, and then the intestine gets divided right after the end of the stomach right there. And then sort of a similar concept of dividing the intestine further down, reconnecting it, and then reconnecting the intestine that has all the digestive enzymes further down. So restrictive in that it has a sleeve, malabsorptive in that you're bypassing a lot of intestine here. So I can spend much more time with that. If you guys have specific questions, I have charts in my office and more detailed pictures, and I'm happy to spend more time explaining those procedures. What are the complications? The most common things, atelectasis, that's just getting a little bit of fluid in your lungs from being put to sleep. That happens literally with any operation, and this risk is no different from any other operation. GERD or reflux, gastric bypass is actually the procedure of choice if you have GERD because it can be curative. Patients with significant reflux symptoms probably shouldn't get a sleeve, in fact, because it can make it worse. However, losing weight in general tends to make GERD or reflux better. But 10% or more of patients may develop reflux after a sleeve, and I would consider that it's Achilles heel. It's otherwise such a safe and excellent operation. Reflux is the one downside, but again, that affects about 10% of people. Wound infections, 1% marginal ulcer. Now, that's specific to a gastric bypass where you can form an ulcer on the intestinal side of that stomach connection. Again, that happens about 1% of the time. Hypertensive crisis, especially if you already have high blood pressure after surgery, this can go up immediately after surgery, but tends to get better very quickly afterwards. And then DVT, deep vein thrombosis, or blood clot formation happens in less than 1% of patients. And we have that down to a protocol where patients give blood thinners while they're in the hospital to try and prevent that. Major complications. So the one in red down there, mortality, so that's the rate of death with these operations. In general is less than 1 in 1,000, so they're very safe. Small bowel obstructions, far less than 1%. Anastomotic leak, so that's long-term. That's either with a sleeve or a gastric bypass or a duodenal switch. And that's where one of the connections or something leaks. Now these are national averages, or these are coming from the national average website, and I'll show some of our specific data in just a minute. Hemorrhage or bleeding, 1%. Stricture is just a narrowing within the intestine or stomach that happens 1 to 2% of the time. What are our actual numbers? So it's easy to just Google these things and say, hey, what are the complication rates for these surgeries? Just over the past year, you can see here that we did have a few readmissions. Almost all of these were related to dehydration, but 3%. The national average is about 3.5%, so we're pretty spot on there. Related reoperations in the patients that we operated on over the past year, only 1 patient had to have a reoperation. So that's actually also below the national average of 0.5%. Gastrointestinal bleeding, bowel obstructions, blood clots, we didn't have any, no deaths during that year. Wound occurrence, so we had 2 patients that developed a wound infection out of roughly 200, so all of these are below national averages. Our leak rate, and when I knock on wood as I say this, has been 0% over the past year. And pulmonary embolism, which is the blood clot that goes to your lung, we've had 9. And those are considered the most common cause of death after bariatric surgery is a blood clot. And fortunately, we are very, very good at avoiding those here. What are some of the long-term complications? So vitamin deficiencies and protein malnutrition, these are more common with the malabsorptive procedure. So gastric bypass and duodenal switch, you're far more likely to have some of the protein deficiencies and vitamin deficiencies. You can get those with a sleeve, but it's a little bit more rare. But once you start our program, you'll know that we will hound this into everyone. Staying on top of your dietary recommendations, taking multivitamins. We check your labs regularly to look for vitamin deficiencies. It's the patients who have bariatric surgery and then never follow up again or move away and forget to see their bariatric surgeon or bariatrician. Those are the patients that you see with the really bad vitamin deficiency complications. Patients who follow up regularly, take the multivitamins, it's extraordinarily rare. It truly is. This is an easily avoidable thing. How much weight can you lose? Now, these are just averages. And again, every patient comes to my office, I'll give you a printout of your specific risk calculator and your specific weight loss expectations based off of your age, sex, race, medical problems. Everybody gets a printout that comes to my office. But on average, you can expect to lose 30 to 40% of your excess weight in the first few months after surgery. Again, at 6 months, you're around 60%. Greg had mentioned you lose up to 70%. Some patients lose up to 80%, depending on the procedure. And that's around 1 year. Now, what we know is, this is a common question I get, you're not going to continue to lose weight that rapidly forever. You're not going to wither away. Most patients between 9 and 12 months, they significantly slow down on their weight loss. And then we enter what's called a maintenance phase. So we're no longer actively losing a lot of weight. We just try to maintain the weight loss that we've had. And a lot of patients will gain 5 to 10% of that weight back over the next few years. Patients gaining back more than that's unusual, and it is an issue, and that is something that we do follow long term to try and prevent. Losing weight can help your body function better. It improves your ability to do things that are important to you. So we talk a lot about weight and percentage of weight loss, and any article you read or any blog you read, they all talk about weight, or how much weight did you lose with the lap band, or how much weight did you lose with the Ozempic, or how much weight did you lose with you name it. Well, I try to remind all of my patients that the scale is only one measure of success, and I would argue that it's the least important measure of success. Things that are far more important are all of the medical problems that are associated with that weight. Sleep apnea, extremely common. 75% of that goes away after bariatric surgery. cardiovascular disease, including heart attack and stroke. So your risk of dying from cardiovascular disease is cut in half after bariatric surgery. High blood pressure, high cholesterol, resolution rates are 90%. Type 2 diabetes, a lot of my insulin-dependent diabetics are off of insulin before they even leave the hospital. It's very quick. Pulmonary disease improved. Fatty liver disease improves in 70 to 80% of patients. In fact, a new study came out last year that 40% of patients with liver fibrosis, so that's extensive liver disease from fatty liver, 40% have reversal of their fibrosis, which is just insane. PCOS, infertility. I like to joke, but it's an actual thing that I, as a surgeon, have the best fertility rates in the whole panhandle because patients have PCOS or infertility related to their weight and they don't realize it. You lose weight and patients get pregnant. And to the point that we really have to encourage patients to take birth control seriously. You don't want to get pregnant right after bariatric surgery. It's hard to grow a fetus and lose weight at the same time, but it happens. I've had patients say that they've been trying actively for 10, 15 years to have children. 6 months after the bariatric procedure, they're pregnant, and it happens very, very frequently. So bariatric surgery is a phenomenal way to improve fertility and have children. Patients ask all the time, well, can I have a baby after bariatric surgery? Well, not only can you, you're more likely to, and you're more likely to have a more healthy and more risk-free pregnancy by weight loss. So yes is the answer to that. Osteoarthritis improves in 80% of patients just by weight offloading. Things that aren't on this list, a new study came out that said if you lose at least 20% of your body weight, your risk of developing cancer cuts in half. So you're half as likely to develop cancer if you lose 20% of your weight. Now, I would argue that that is another thing that separates bariatric surgery away from some of these medications and injections, is it is very rare with the injections to lose that kind of weight. If you want the benefits of these, sleep apnea, cardiovascular death risk, cancer risk, bariatric surgery is the way to get there. It's just more effective, and this the way it is. The average patient after bariatric surgery gains about 9 years to their life expectancy. I also saw a very, very troubling one, since I'm on the access to care committees for bariatric surgery and trying to improve access for patients across the country, that 3% of patients who are denied for bariatric surgery die within the first year. So we're not talking about weight. I can't overemphasize. It's not about the weight. It's about living longer, cutting your risk of dying by heart attack, stroke, or cancer in half. This helps you live longer, and I think that's what it's all about. This is more of the same. I'm just running my mouth and kind of ruining the slides ahead of me here. So how do we do these things here at bariatric surgery or at TMH? They're all done robotically now. We've almost completely gone away from laparoscopic surgery. I did a lot of sleeves laparoscopically early on, and patients just don't hurt as much with robotic surgery. And I think that's just less manipulation of the abdominal wall. It's far less painful to do it robotically. All of our procedures are done in under 2 hours. Now, there are exceptions to that. I do a lot of revisions and conversions. Occasionally, I'll fix big hiatal hernias at the time of the bariatric surgery. But a straightforward sleeve is about 30 minutes. A straightforward bypass is about an hour. I would say 95% or more of my patients go home the morning after surgery. It's gotten pretty rare to have to keep anybody for 2 nights. And most patients, depending on what you do, are back to work within 2 weeks. Sort of sedentary desk jobs, patients are back within a week. More strenuous jobs may take a little bit longer than that. New studies came out that said bariatric surgery, or specifically a sleeve, has the same risk profile as laparoscopic gallbladder removal. So this stuff is safe, helps you live longer, it's cost effective. The average insurance company states that the bariatric surgery pays for itself within 22 months of surgery. So yeah, there is an upfront cost, but the lifetime cost savings is profound. There's 70% of lifetime medical cost savings after bariatric surgery. And again, the savings pay for itself within 22 months on average. Insurance information. So this is just kind of like a blueprint here. Most insurance companies require that your BMI be over 40 to qualify, or if you have medical problems associated with your weight, then the BMI down to 35. Some newer insurance companies are allowing for a BMI down to 30 if you're diabetic, but that is only very specific types of insurances. So we are here to help you. I mean, we're here to help sort of navigate what your plan is. Some of these insurance companies do require that you call directly, and they will only give us limited information, but we do have a rough idea of most insurance company policies. That's just something you'll just have to either call or come talk to us about specifically. And that is my part. Again, I kind of wanted to go through that quickly and allow time for questions if you guys have any. So I am all done.
I see we have a question with the raised hand. Macy, are we able to?
Let me see if I can unmute it. We do have one in the Q&A box right now while I go to unmute that.
Okay.
Somebody asked,
For this one in the Q&A, will this be posted anywhere to refer back to it? Yes, it will. There will be a link. Is it on the TMH YouTube channel, Macy?
yes, it'll be on YouTube, and then tomorrow we plan to send out an email with the link to that as well.
All right. We have anonymous attendee. When is the sleeve recommended over the bypass? I'll let Dr. Jarrard take that one.
I guess I can handle that one. In general, we would consider the sleeve sort of the baseline. I do think that's the most commonly offered procedure, mainly just because it's easy, fairly straightforward, very safe. Again, the procedural length and the risk profile is very similar to having your gallbladder removed. So it is a very safe operation. In patients who have had previous surgery on their stomach, in patients who have really bad acid reflux, large hiatal hernias, complications related to reflux, so strictures, Barrett's esophagus, anything related to reflux, we would generally steer you away from a sleeve and towards a bypass. That being said, if you have none of those issues, in general, most patients will choose a sleeve up front. Now, I do have patients that choose a bypass up front even without reflux, just because of personal preference, or they have a family member or friend who did well with a bypass. I think that's very reasonable. I kind of go through these guidelines with you in the office, and if I really think you'll benefit from one over the other, I'll tell you. But if you have no strong contraindication,
Thanks, Dr. Jarrard. We've got lots of good questions coming up. Here's one for Greg. Do you assist with weight loss meds? I have CHP.
Fine. Yeah, there's the HMO dictates coverage. They'll allow us to use certain things. The vast majority of HMOs will not cover obesity medications. So first and foremost, now, can we write those and can we prescribe them? Absolutely. But the question is going to be, what's the coverage going to be based upon your HMO? The vast majority of the time, it's not covered, but there are some affordable medications that can be discussed when you come in. Yeah, so that is an option.
Okay. Next, we have, if I have an HMO, how do we get the process started? Typically, we would start with a referral from your primary care physician over to for a surgical consult. It's usually how that would start. And when we do our follow-up email, I'll have a list of next steps with Dr. Jarrard and Dr. Parker's office information, how to refer. I'll have a form in there that can guide you in talking to your insurance company to find out if you have bariatric surgery coverage. Yeah, we would need to start with probably a referral or an appointment for a surgical consultation.
And I've seen a couple of questions on there. I do encourage patients that are interested, even without a referral, call. I'm happy to see you get an appointment. Now, at some point, we will strongly encourage a letter from your primary care physician, supporting or clearing this, or sort of that would sort of be the referral. If you don't have a primary care physician, you're going to need to get one. The surgery is fantastic. Greg and his capabilities are fantastic. As far as maintaining your overall health and the medical problems associated with their weight, we're going to need a lot of help with that. And that's what primary care physicians are good at. So do you have to have a referral to get an appointment? No, not necessarily. We encourage it. But you can also call and get an appointment. And we can kind of work those things out on the back end as well. Now, a lot of this stuff is insurance driven. Now, I'm going to be careful how I word this. I'm answering someone's question here. It is insurance driven. Now, we also believe in the process. We also have learned a lot over the past 20 years that chop shops, you come in, get surgery, and good luck, like Mexico does, fail. Patients have complications, significant complications. In fact, I take a lot of those patients. I take care of a lot of those patients that go have surgery somewhere else, have really no idea what they're supposed to be doing or eating, and have complications, and it's a disaster. So we very, very much believe in our process, the importance of a multi-modality workup approach with our bariatricians, our dietitians, our mental health providers, attacking this from all angles. So I'm going to preface what I'm about to say with, we believe in the process. That being said, there's also insurance requirements, because I'd like to believe that insurance is believe in the process too. I think they just like to get more money off of you. But they also require a certain number of bariatrician visits, a certain number of dietitian visits. Everybody has to have mental health clearance. These are insurance requirements. Seeing me a certain number of times, those are insurance requirements. Now, every insurance is different. Some insurances literally require a certain number of visits over any time period. Some insurances require at least one monthly visit over a certain time frame, up to 6 months. Certain insurances require a minimum of 6 months of a program with any variation of visits to approve it. So a lot of that is dictated by your specific insurance company, and we would have to talk to you individually about your requirements. But someone asked about why is it 3 to 4 months? We believe in our process, but even if we're trying to go quickly and get you through as fast as we can, it still takes at least a few months to get all the evaluations and the appointments scheduled that you would need to get done. As far as, our statistics for weight regain, I could not tell you that off the top of my head. And that thing it's a bit difficult to follow, because a lot of our patients that regain their weight are the ones who don't come back or follow up, and they kind of get lost to follow up. And we call and call. We have a protocol. We call them at least 2 or 3 times, send emails, and they don't come back anymore. And then, those are the patients you see 5, 10, 15 years later who have regained all their weight. So that is a very hard number to track for us of the patients regain. The patients who are compliant, who we're actually able to measure their weight on the scales every year long term, numbers are pretty good. I'd say it's acceptable for a patient to regain 5, 10% of that weight back over the first few years. I think that's very reasonable. To gain more than 20% of your weight back, that's abnormal, and that's something that we jump on right away, whether you would need additional surgery or additional dietary counseling, or if you're a candidate for some of the weight loss medications after your surgery. That's a very, very good role for those to try and avoid weight regain. So of our patients that continue to follow us and we're able to track them and measure their weights, I would say less than 20% have significant weight regain in the first few years after surgery. Skin procedures. Sorry, I'm just going to run off here and answer as many of these as I can all in one breath. Skin excess. So I tell most patients skin excess is an under the clothes problem, not an out of the clothes problem. So even if you lose 200 pounds, most people that walk by you can't tell that you have excess skin. It's sort of an under the clothes problem. That is difficult to get covered by insurance, and we typically partner with our plastic surgeons to get help with that. And that, again, that's something we can offer more information on. We would generally wait at least a year after your weight loss procedure to make sure that you're done losing weight before you get any kind of skin removal procedure, because you can continue to lose weight and then have even more redundant skin. It's not a problem for everybody, believe it or not, but in those patients who have excess skin, they're developing rashes and infections related to it, insurance will often cover those types of procedures. But we partner with our plastic surgeons here in Tallahassee to have those conversations. Let me take a breath and let you guys hit through a few, or it's up to you.
We have one here that says what kind of preparation is needed for the surgery. I think you kind of touched on that as far as some of the insurance-driven requirements, and that is definitely, the bariatrician visits, the nutrition visits, mental health clearance, some of, depending on your health history, you may need additional clearances. So hopefully that kind of answers that question. Let's see. Do you have to be on a liquid diet before surgery, or can you still watch your calories? That is good. Our dietitians, the way they do their preoperative diet is one-on-one patient specific. Some patients do all liquids because that's easier for them. Some have a specially formulated preoperative diet by the dietitian that is low carb and still gets the job done, but they may offer some meals. It just depends on their specific requirements, their BMI, lab work done now.
It's not just about calories either. There's components of it. It's low carb. That's very specific, dietitian specific. It's very beneficial for you to have that specific diet before surgery, because it really shrinks your liver. Your liver shrinks very, very rapidly with a low calorie, low carb diet. Shrinking your liver out of the way makes surgery easier for me. And if your surgery is easier for me, it's going to be safer for you. So it is important. It's a pretty specific 2-week diet before surgery. I know that's highly variable for different programs. Some programs only require a week. Some programs only require 10 days. We kind of protocolize that at 2 weeks with some exceptions, but very few exceptions. I hope that answered that question.
Now, do you want the lab work done now or closer to next appointment? That's something that can be addressed at your first appointment with Mr. Greg over here. If you don't already have lab work done, he usually will order that at your initial visit with him.
Previous bypass, you would not sleeve a bypass. That's not a thing. There are certain issues you can have with the gastric bypass that can be corrected, especially if you had a lot of success early on but regained. Some of those issues include, I've seen a bypass reverse itself. So the bypass part of the stomach, an inflammatory connection happens to the pouch. It's called a fistula, a gastric fistula, and the fistula got so big that everything the patient ate, it just went through the old stomach and through the old pathway. So a gastric fistula is something we can look for and correct. Sometimes your gastric pouch, whether it was left large at the initial surgery or gradually dilated and stretched out and got larger over time, that's a real thing. So any patient that I have who's had a gastric bypass, if I'll do imaging, I'll do an endoscopy, we'll get a good look at everything. And if everything looks fantastic, you got an appropriately sized pouch and everything looks good, well, I'm really going to push you towards the non-operative obesity medicine pathway, because you got the tool still there. You just need to kick it back off. But I do a very thorough evaluation for a dilated pouch, gastric fistula, or anything I can come up with that I can correct. Now, revisional surgery at baseline has a 15 to 20% complication rate. It is more complicated than the numbers we gave you. That's upfront surgery. So at the end of the day, I'm comfortable doing every bit of it because I do it all the time. I do all the complicated revisions from all over the southeastern United States. I'm comfortable doing it, but I also owe it to you. If we can do medications instead of a procedure with a 20% complication rate, then if I can't find something specifically to fix, I'll oftentimes encourage you to go a different route. But I do revisions very, very frequently, and hope that answered your question. If there's an issue with your bypass, I can fix it. If there doesn't appear to be an obvious issue with the bypass, we would push you towards a medication route instead.
Awesome. Debbie says, do I need to switch gyms? Absolutely not. If you have a gym that you go to that you like and you're established at, that's, by all means stay there. You do get a free consult with Christine Morse at Premier Gym. So you would just schedule a time with her to meet with her. She'll go through some really good information on how to get started and how to maximize your workouts. And then you can take that information that you learned and use it at your own gym. That would be fine. Do you prefer to do your own EGD prior to surgery? Yes.
Not anymore. I mean, I used to do that. I used to be very rigid about that. A lot of the times we avoid EGDs in patients who are low risk, have no GERD, and just want a sleeve. We'll do an upper GI instead just to evaluate and screen. And I would say 80% of those patients screen normal and don't need an EGD. If they screen for abnormalities on the upper GI, then we would do an endoscopy. Pretty much all my gastric bypasses will get an endoscopy because we're going to, reroute things where we will no longer have access to part of your stomach. So we do want to evaluate that stomach before a gastric bypass. I used to like to do all of mine. I now have a pretty good relationship with our gastroenterologist here. So they do a vast majority of my endoscopies now just to kind of help take some of the load off of me because I spend a joke. I spend 80% of my time in the OR, then 60% of my time in the office. Kind of all over the place all the time. For complicated revisions, so if I'm looking specifically maybe for a gastric fistula, or if you had a major complication from an outside facility, I'm thinking I may have to take your stomach and do anything with your esophagus. In those scenarios, I would want to do the endoscopy myself just to look exactly what I'm doing. But for screening for straightforward bariatric procedures, I usually let my gastroenterologist do those.
All right, we've got, what is the longest someone would be out of work for the different procedures?
Well, the longest, assuming everything goes right, again, most of my patients, if it's a sedentary office job, within a week, you're ready to go back and sit in front of the computer with your water bottle. I tell everybody to plan for 2 weeks. Most people don't need 2 weeks, but plan for 2 weeks off of work. And you're usually ready to go back before then. Now, if you have some extreme labor job, it may be longer than that. I had a law enforcement officer that very specifically like goes and chases people down and tackles them. Well, we may want to do 4 to 6 weeks, make sure you're really, really good before you do something extreme. I'd say by and large 2 weeks is the average for patients that are fully ready to go back to work. How soon are you back and moving around? My protocol is 8 hours after surgery. You are walking the hallways. I'm very, very aggressive. You got to get up, you got to move. So you can walk right after surgery. As far as full throttle, I don't really have any limitations at all. We're probably maybe 2 to 3 weeks out.
And then how soon can you eat solid food?
Dietitians are going to love to answer all those questions for you. You're gonna be so overloaded with education from our dietitians. But in general, we do the 2 week preoperative diet. You'll get clear liquids while you're in the hospital. You'll go home the day after surgery on a full liquid diet for 2 weeks, and then we do pureed food for 2 weeks, soft foods for 2 weeks, and then it's regular after that.
Lots of good questions.
And that's literally everything I know, so I don't think I can answer anything else.
Well, we've run over time anyway, so I'm glad that everyone got all their questions answered. If you think of something that you didn't get answered tonight, please feel free to email me, call me. It's I think I can type it in the chat here. We have one last question. What can you tell me about pain?
I like this topic of pain. No surgeries without pain, period. Unless you get, a nerve block for an orthopedic procedure where that nerve block's going to hurt. Like nothing is without pain. Now, that being said, our understanding of how to treat pain has significantly changed over time. And I think a lot of that was incentivized by the sort of opioid epidemic and all the fears associated with that. So we have a big, big, big push to limit narcotics for a number of reasons. I have found anecdotally early on that a lot of my patients who were needing additional pain medications were also the ones who stayed dehydrated, stayed nauseated, had more, they spent more time in the ER. So we implemented a very strict protocol with how we give IV Tylenol, muscle relaxer, nerve block, steering surgery. And what we've noticed is after surgery, patients need way less medication. And because of that, we got away from narcotics after surgery. So I stopped writing narcotics after bariatric surgery. So you get Tylenol, muscle relaxers, you'll get some ancillary things. And I thought it was just anecdotal. So we tracked that data. And after a year of not prescribing narcotic pain medication, our ER visit rates cut in half. Our dehydration rates cut in half. And that's because all of those narcotics, they mask pain in your brain, but they induce nausea. They make you sicker. They make you not feel as good. And I also saw a recent study that showed they blinded three groups of patients with pain, and they treated one group with placebo, one group with hydrocodone, and then the third group with alternating Tylenol and Advil. And what they noticed is the patients getting placebo, which is just a sugar pill, had 10% improvement in their pain. Patients getting hydrocodone had 20% improvement in their pain, and then patients getting a multimodality therapy without narcotics had 70% improvement in their pain. So I'm a big fan of limiting and avoiding narcotics. If you need it while you're in the hospital, you'll have it. We very rarely send patients home with narcotics. And patients don't need it. Patients never call back and say, hey, I need some oxycodone. I'm in a lot of pain. I never get that phone call after a bariatric procedure.
I think we said one last question and then there's one more. I guess we can take it. I experienced childbirth since my gastric about 20 years ago and have put on more weight, but haven't put it all back on. I'm still considered obese and it's hard to get it off. Do you think I would be a good candidate?
I see patients just like you all the time, and there's a lot of factors and variables that go into that. So we're happy to see you. I'm happy to look at your history, what exactly you had done, where you're at. And if I think you're a surgical candidate, I mean, you can ask Angie, you can ask anybody, I will do the best surgery available to you. If I think you won't benefit from it, I'll put you over to Greg because I have full faith he's going to do an excellent job too. I do not like to operate if I don't think it's going to help, but I'm happy to meet you and talk to you more about that in person.
Absolutely. I can attest to that. These guys will get you taken care of. They'll let you know what you're a candidate for and help you make that decision. Please be on the lookout for an email from me. You'll get a follow-up email with the items we talked about. I put my email and phone number in the chat. Please feel free to reach out to me if you have other questions or need assistance in getting an appointment scheduled. I'm more than happy to help you.
Raffle.
And we're going to do a drawing. We're going to pick a random person for the Publix gift card, and we'll let you know who the winner is. We'll reach out with the information that you used to register for this webinar. So one lucky winner tonight, and you'll find out about it tomorrow.
Is Greg and I in the drawing?
No, you're not qualified for that.
Right.
Well, thank you guys for joining. This is a great turnout. I hope we answered your questions. If we didn't, please come let me answer them for you in person.
Thanks, everybody. I hope you all have a good night.